Hi, everybody. Good afternoon. I'm Carol Hodson. I'm the Executive Director of Monash Partners, and it's my great pleasure to welcome you to this webinar. We're going to be talking about the true costs and impact of implementation efforts. And before we start, I would just like to start by acknowledging the traditional custodians of the land on which we're all meeting. For me, it's the Wurundjeri people of the Kulin Nations, and pay my respects to elders past and present. And we'd particularly like to extend our respect to any Aboriginal and Torres Strait Islander people joining us today. So we are very fortunate. We've got two great speakers today. I'll introduce them in just a moment. The webinar, for those of you who've attended before, you know that the webinars are always made available after the event. Please feel free to introduce yourself in the chat below. You can use the question and answer function if you want to post a question for Lane or Tommy. And if you want to use social media, please use hashtag MP Events 2026 across any social media. So I'm going to introduce our two speakers. The first one is Lane Meredith. Lane is an early career researcher who actually works with my group and is absolutely fantastic. She's a researcher in health economics and implementation science, based with me at the Australian New Zealand Intensive Care Research Centre, or the ANZAC-RC. So we're in the School of Public Health at Monash University. She specialises in developing methods to integrate economic evaluation with adaptive platform trials and design studies that generate decision-ready evidence for implementation and policy. And her work aims to bridge the gap between trial evidence and real-world impact. And I've had the pleasure of working with Lane on several of my randomised controlled trials, and it's always been an absolute pleasure. So Lane will be our first speaker, and then we've got Thomasina Donovan. Dr. Donovan, or Tommy, is an early career researcher. She's based at Queensland University of Technology in the Australian Centre for Health Service Innovation. So Tommy works collaboratively with multidisciplinary stakeholders, applying implementation science and costing expertise to projects. So she finished her PhD on methods for collecting and estimating the costs of implementation strategies in healthcare settings, and she combined the knowledge from the fields of health economics and implementation science to develop a costing implementation strategy called the COST-IS. So we're all really excited to be hearing about Tommy's work and the COST-IS. But first of all, Lane will speak to us. So I'm going to stop sharing, and Lane, I'm going to let you share your slides. Thank you very much.
Great. Thanks so much, Carol. As Carol said, I'm Lane, and I'll be kicking off today's webinar on understanding the true costs and impact of implementation. I'd also like to acknowledge the traditional owners of the lands that I'm joining in on today, which is also the Wurundjeri people of the Kulin Nation, and I pay my respect to elders past, present, and emerging. So not only are health services facing increasing pressure to deliver evidence-based care, but now we're also expected to deliver value-based care. And it can be really challenging to not only define value-based care, but also to understand how best to do it in a particular context. And so there's a real opportunity with implementation science and health economics to help support the generation of that type of evidence alongside our wonderful RCTs and our clinical studies. However, there are challenges in doing this. It's really hard to estimate the costs and outcomes associated with delivering value-based care. It's difficult to define what value means in the delivery of care and how we scale and sustain that service delivery model. So I thought I would start with making a distinction between the intervention and the implementation strategy. And then I'll talk about how we generate meaningful economic and implementation evidence to support the delivery of value-based care. I heard a great talk from Jeffrey Curran about implementation science when I was first introduced to the field. And I found this slide on non-scientific language really helpful, and it's actually been published in Implementation Science Communication. So when we talk about the intervention, he says it's called the thing. So the thing that we're trying to implement. So effectiveness research looks at whether the thing works, whereas implementation science research looks at how best to help people do the thing. Implementation strategies are the stuff we do to try to help people do the thing, and implementation outcomes are how much or how well they do the thing. So in terms of implementation strategies, there's a lot of strategies. Byron Powell published a compilation of 73 strategies, and there's some great resources out there, including some of the previous webinars that Monash Partners has held around how to choose the right strategy depending on your context, which I won't go into today, but there are helpful tools out there, and this is a helpful list of those different strategies. There's also a taxonomy of implementation outcomes. This was published by Proctor, and I believe there's 8 different strategies, including acceptability, adoption, fidelity, sustainability. But I thought I would go through an example of this distinction between the intervention and the implementation strategy and how you might measure the costs and effects of each discretely. So the thing that I'll be talking about today is switching from intravenous antibiotics to oral antibiotics. So if we were to measure the effectiveness of this intervention, we might look at a reduction in infection risk, although there are other outcomes that you can also choose from. And then the costs associated with those two interventions might be the drug cost or the preparation and administration time for the drug. And you might also look at the length of stay associated with each patient group that receives the different interventions. And this is distinct from the implementation strategies. So there are many different types of implementation strategies. As I mentioned, there's a list of 73 different ones, but some common ones might be clinician education programs, audit and feedback, or electronic medical record prompts. I've heard in many health services that they often they take a kitchen sink approach where they do all 3 at once, but there are options of using a step wedge design or implementing one strategy in one setting and another strategy in another, or you can do a pre and post. So there's lots of different options in terms of how you might measure the effectiveness of different implementation strategies. But as an example, the effect measure for these implementation strategies might be the number of unnecessary IV doses administered. And the costs associated with the implementation strategies might be the time required for staff to be involved in education. There might be additional IT specialists that you have to employ to roll out the electronic medical record prompts. There might be a person you need to hire to develop educational materials. Maybe you need to educate the pharmacy staff in order to facilitate the audit and feedback system. So these are the sorts of costs associated with the implementation strategy that's separate to the intervention. And so let's say you were to run a trial and you had your intervention and your implementation strategy. For your costs, you would have your fixed and variable costs, and you would have your patient outcomes, and that's how you would run an economic evaluation of the intervention. And as I mentioned, there are many different types of effect measures that you might choose. It could be that infection risk reduction, or it could be other patient-reported outcome measures. And typically, it's recommended that you take a longer time horizon, maybe a year to 10 years, 5 years to a lifetime. And the recommended perspective is societal. So you would capture all relevant costs, including the costs incurred by the hospital, by the healthcare system, by the patient, by the carer, etc. And this is, again, distinct from the economic evaluation of the implementation strategy. You have your fixed and variable costs, but your effect measures are different. And these are some of the outcome measures that I pulled from the taxonomy published by Proctor. And typically this is a shorter time horizon, so it maps onto your implementation period. And the recommended perspective in this case is an organizational perspective, so whether that's your hospital or your unit, but it's typically sort of a narrower perspective than the societal one that you would take for the intervention. So again, for the economic evaluation of the intervention, we have our fixed and our variable costs as well as our effect measures. And then we would run a cost effectiveness analysis to get a ratio of costs and effects, which could look like a cost per infection avoided or a cost per quality adjusted life year. And now I'm not expecting you to go away and be able to run an economic evaluation on your own, but hopefully by learning this terminology, you'll be able to have a conversation and begin to understand these different types of terms. And if you have a health economist on your team, you can have conversations about how you might measure the intervention versus the implementation strategy. So, building that capacity to have those conversations. And so for the economic evaluation of the implementation strategy, again, you have your fixed and your variable costs, and you have your effect measures. And the different types of economic evaluations that you might run alongside your trial might include a budget impact analysis, a cost-benefit analysis, or a simple comparison of the costs and effects between people involved in the implementation strategy versus those who aren't. And some of your outputs might be a cost savings associated with the implementation strategy or a cost per unnecessary IV dose avoided. And the optimal sort of economic outcome that you would get would be a ratio of the cost savings and the effects. So if you get a reduction in cost and an improvement in outcomes, that's great. That means that your intervention or your implementation strategy is cost effective. And so health economists like to weigh up the cost savings versus the effects, and they do this through a ratio. So using existing literature, I'll just run through what a cost effectiveness analysis does for switching from intravenous to oral antibiotics. And this is a published trial. So you can see that in this table, we have a cost savings associated with oral antibiotics of 2,215 British pounds. And there's a small but improvement in quality of life associated with oral antibiotics. So because we have cost savings and improved outcomes, that means that oral antibiotics is cost effective compared to intravenous antibiotics. Now let's say we want to run an economic evaluation of the implementation strategy. And these numbers are illustrative, so they're not real, but this is just to show how you might go about collecting the different costs and effects. So I placed each individual implementation strategy in separate lines. So for education, costs about $5,000, whereas electronic medical record prompt notification would be about $20,000. And then you might measure pre and post to look at the unnecessary IV doses administered. So you have a reduction in the number of unnecessary IV doses administered at 2% for education versus 4% for electronic medical record notifications and 5% for audit and feedback. So if you have a sample of 10,000 patients, you can see that the most cost-effective the most cost-effective implementation strategy might be education, depending on your willingness to pay for a reduction unnecessary IV doses administered. So this is like I said, this is illustrative, but you can see that it's really important. And so once we distinguish the intervention from the implementation strategy, we can see that there is benefit to improving the use of oral over intravenous antibiotics. But maybe you've decided that you really think that you want to conduct some research in your health service to advocate and to improve the uptake of oral antibiotics. And it can be really hard to get the funding to do this sort of work. So as the final component of my PhD, I created a calculator, which is called RORI, or the Expected Return on Research Investment Calculator. And I'm very happy to share this as a publicly available website. It's still being tinkered with and finalized, so I'm also open to any feedback that anyone has, but I'll run through how it works and how it can be used to advocate for implementation research. So one of the first steps is to define your scenario. So we'll stay with the oral versus IV antibiotic scenario. So let's say we have 10,000 patients who receive antibiotics each year, and we want to swap them from oral to IV, or sorry, from IV to oral. So we want to improve the uptake from 10 to 15%. The economic assumptions that this is from that published cost effectiveness analysis. So we have an improvement in QALYs of 0.0001 and a cost savings of over 2,000 British pounds. Our willingness to pay threshold that's commonly accepted in Australia at $50,000 per QALY. Our economic benefit time horizon is also pulled from our cost effectiveness analysis, the published one, which is 1 year. The annual discount rate is that's also just a default 5%. And we have our perspective. We also put in the cost of our proposed research study, which in this case, I'm going to advocate for $1 million to run this trial of comparing oral versus IV antibiotics and that implementation component in my setting. You can switch it to 5 million, depending on maybe the funding available for doing this sort of research. So if you were applying for an NHMRC of $3 million, then you could change that figure. And the anticipated implementation costs, I just simply added up the different strategies, and that's going to be $35,000 over 1 year. Another component of RORI is that you're able to build your or design your trial. So you can stipulate your implementation strategy. You can select your implementation outcomes based on the taxonomy that I mentioned earlier. You can also choose your cost perspective and the different implementation costs that you might collect in your trial. And you can also indicate the type of economic outcomes that you'd like to look at in terms of the intervention. So you could do a cost utility or a cost effectiveness analysis, and you can choose the resource use that you'd like to collect. And so the summary tab in RORI, in addition to your key results, it also shows your proposed study design, which can be downloaded as a PDF. But the key results here is that you spent $1 million and there's a $75,000 benefit associated with improving the uptake of oral antibiotics by 5%. And so every $1 invested in your research program, you get 7 cents in return. So it's not very big, but it is positive. And this is the sort of this is how you might define the value or quantify the value of your research, of your implementation research in real terms. And the model behind it is a type of economic and implementation methodology that can be used to design your trial, but also to look at sustaining and scaling your implementation on a much larger scale. RORI also includes a resource library, which is, I referred to some of the resources that I found helpful, and that's all being added onto that tab number 6. So in conclusion, I hope that what you take away from my presentation today is that there is an important distinction between the intervention and the implementation strategy, and that's important for getting accurate and meaningful outcomes, but also for demonstrating the impact of your research. And so economic and implementation outcomes, although they're often an addendum to clinical outcomes, they're really important, and they can be used at the outset, or they can be helpful to consider at the outset and can be used at the outset to prioritize your research, to secure funding, and also to support scale up. So I provided my email there. Again, I'm happy to share my slides. I'm happy to share the RORI tool, and I'm very open to feedback. And I will on that note, I will hand it over to Tommy.
Thanks, Lane. I'll just share my slides. Okay, wonderful. So hi everyone, I'm Tommy or Thomasina. I'm a research fellow at OSHI up at QUT. And I want to thank Monash Partners for having me today. Before I start my talk, I'd like to acknowledge the country that I come from, which is that of the Yagara and Turrbal peoples. So thanks, Elaine. We now have a little bit of an understanding of how implementation costs can impact the value of the intervention that you're trying to have uptaked in your health service. But how do we actually cost implementation? And I'm going to show you one method to costing implementation that I developed in my PhD. But before I get into that, I want to give another example of what is implementation strategies and cost in kind of the pipeline of research, because getting this distinction between intervention costs and implementation costs is very tricky, but needed for this type of work. So in my example, I think about, imagine you discovered a new gene that can detect whether someone's going to get cancer. This is great because then we can save lives and improve people's lives. So now we know what gene it is. We have to develop a test so that we can actually detect the presence or absence of that gene. Great. But this isn't the end of the story. You actually need to get a doctor or a health professional to order that test for their patients. Otherwise, their patients aren't going to receive the test. And this is where implementation science comes in around this uptake of the intervention. So you could use different strategies as Lane mapped out. There's many that you could choose from that list of 73. But here are some examples. You could have one at the provider level, so you could educate your doctors and increase their awareness that there is this test. You could have a strategy at the practice or service level by changing infrastructure, for example, including the test on their electronic ordering system, or you could change the system level. This would be a bigger thing about altering the incentive structures, and in our case in Australia, maybe including it on the MBS to reduce barriers to access. So any of those strategies that you end up choosing, they cost money through the resources that they take. And this is in addition to the money and resources that are needed for running the tests for the absence of that gene. But both of these resources are needed to ensure that this patient receives this certain care. And if we forget about the resources for implementation or not incorporate them, then the patient isn't likely to get that care. So this is another example of why implementation costs are important and what they could look like in another scenario. So how do we cost implementation? Well, in 2020, I think it was, someone did a systematic review to capture all the instruments that measure the different implementation outcomes. So those were the 8 implementation outcomes, like adoption, acceptability, sustainability, and cost is another one of those outcomes. And so they gathered all the instruments that they could find that were validated and put them into this repository, which is available online and is actually great because you can see all the validated instruments. But through their research, they could not find any validated cost instruments. And so this is where my PhD came in to develop a costing tool. So my tool is called CostIS, which stands for Costing Implementation Strategies. And I'll briefly take you through how we developed it in the PhD. First, we started with a review of the literature to identify current practice and methodologies. We did this in a subsection of literature around digital health. And so we wanted to know how people were currently costing. But what we found was that implementation costs were not often reported separately. They could have been captured in the costs overall, but we couldn't tell that. And when they were reported, the methodology used to get that and what those costs included was not very clear. So then we ran some interviews of people who were likely costing implementation. So that included health economists and implementation scientists, because we thought perhaps people just weren't reporting it in academic literature. So we asked them in semi-structured interviews, how are you currently costing implementation and how would you like to? After this study, we were able to develop a prototype of the COST-IS instrument, and then we went back to those stakeholders to confirm that their wants and needs were being addressed. And this is done through a modified eDelphi. At this point, we had a pretty good version of the instrument, and I took it to 3 case studies to do some preliminary validation. And after that, I refined it a bit more as well. So now I'm going to show you what the tool looks like. And it is an Excel workbook made up of 3 sheets for each of the 3 templates. The first template is for planning. The example I have here is just a worked example. So in this template, you would list your implementation strategies, then the activities that you need to operationalize those strategies, and the resources needed to support those activities. In template 2, you capture all of the costs. So it's similar to a logbook based on time-driven activity-based costing and health economics, but you list every time there was an activity, who was involved, and how long it took them. And this sheet is flexible. You could add more columns if you wanted to add more granularity to your analysis. So, for example, on the left, we see phase and date, which means at the end of this analysis, I could look at the data by phase or date if that was of interest to me. Then template 3 is where we value our resources, and in implementation strategies, the majority of our resources are labor-based. So I have that at the top and then the non-labor at the bottom, which can be training materials or travel. But yeah, so I list that down there. Back up the top with the labor, I would find the salary rate using publicly available data, and then calculate their hourly and add on any on costs that are relevant to the study. And now I'll show you an example of how you could analyze the data once you have it in this form. So you may want to look at it by implementation strategy. And so we have the 3 case studies here, and I've organized the strategies into that ERIC cluster, which was that list of 73 strategies. So from this, we can see that most case studies used more than one strategy from different clusters. And we can see that provide interactive assistance, which is around that facilitation, was common across all 3. You could also look at the data by labor and non-labor if that was of interest, and we can see labor is the main contributing cost to implementation, with study C not having any non-labor at all. This was also split into side team versus project team for interest of where most of the resources were coming from for the implementation. So that's a bit of background about the COST-IS tool and how it was developed and what it looks like. Now I'm going to explain how I used it in one of those case studies. So this was costing the implementation of a hospital avoidance program. And it was part of a bigger study, which was the cost consequence of this program, which was called EDDI, or Early Detection of Deterioration in the Elderly. So this cost consequence was made up of implementation costing, as well as the intervention costing and some health service use and costs. But today I'll be focusing on the implementation costing. So when I ran, I think phase 4, when I did the 3 case studies to see how the tool worked, I found the similarities in steps of costing implementation strategies And I found that these 4 steps were kind of what you needed to do or go through to cost the implementation. And I hope this serves as a bit of a guide for people who are approaching implementation costing. So I found you had to understand the project really well. And this was particularly for someone coming into the project a bit later, perhaps if you were on the project the whole way through, this step wouldn't be as long of a process. Then you have to identify what's implementation, what's intervention, and then what are the activities and resources associated with each. Then you document them and value them. And although this seems pretty linear, it was definitely an iterative step where we're going back and forth between them. So first, let's understand the project in this example that we're going to go through. So this was the EDDI project, which was a stepped wedge randomized cost trial, which ran from March 2021 to May 2022 across 12 different sites, which were residential aged care facilities in the southeast corner of Queensland. And this corner contains our metro, regional, and outer regional areas. I'm now hopefully going to play a video which does a really good job of explaining the study. Oh.
Tommy, is there meant to be
Okay.
sound to the video? There's just a couple of
Yes,
questions.
there is. I was just seeing that come through now. Okay, I
Apologies,
will.
I thought it was just an animation without sound.
No, that's all good. I was hearing the sound, but that is not helpful to others. So that's all good. I'll quickly push on. So as a summary to this project, what they were doing is trying to avoid unnecessary hospital transfers of the residents by identifying early deterioration of the residents. So as an example, UTIs could be identified early before they became a big infection problem. But they wanted the personal care workers to do this identification. And so what they had to do is upskill the personal care workers to have the training to be able to make these decisions. So this figure here kind of summarizes the study. So in each residential aged care home, they received specialized diagnostic equipment. So for example, a bladder scanner, so they could see or make a decision using that. They were given education and training because these personal care workers were not trained as nurses or other healthcare professionals, so this is new knowledge to them. And they were giving a decision support tool to help them make that decision on whether they needed to transfer a resident to hospital or not. Then the 4th part was this implementation facilitator who was on site and able to help with the process. Sorry, 1 second. Okay, so now we have understood the project a little bit more. Now we have to identify what's implementation and what's intervention. So in this project, we classified these top 3 as the intervention. and the bottom as implementation. And I like this example because education and training is typically quite a common implementation strategy, but for this project, we included it as the intervention. And the reason for this is we felt it was critical to the intervention itself. The personal care workers did not have the knowledge needed to identify whether a resident needed to go to hospital or not. And so the intervention would not work without this training. This step of separating intervention and implementation is very challenging. And there's a few ways to think about it. And the way we like to is implementation activities are supportive and wraparound, but they're not critical to the intervention itself. So the intervention should be able to run on itself in, a site that's like a gold standard. It's got all the enablers, none of the barriers. If the intervention can run there without anything else, then that's the intervention. But once we bring in these wraparounds, they're the implementation. Okay, so now we've split it up. So what are the activities or resources associated with each? So for intervention, we would have the equipment and those related consumables, all the training, that including upfront, ongoing, and the travel of the nurse educator to go to all those different sites is intervention, as well as any additional consumables needed for that. Implementation would be the ongoing facilitation, and an initial context assessment was conducted to see where the barriers and enablers were for each site. For the health service use and costs, they measured ED transfers by data linkage using the residential aged care home data with ED and hospital admission databases, and cost included ambulance transfers, ED presentations, and hospital admissions. So still just focusing on the implementation. How did we actually measure this? So yeah, now to the document and valuing steps. So the cost AS was used as the data collection template as intended. And the data sources I used were field notes that were collected by the project manager, meeting minutes to identify who was there and for how long, activity logs captured by the on-site facilitators, and internal facilitator check-in forms. To value the different costs, for labour, I use publicly available salary rates, and for non-labour, I use clinical facilitator packs. Sorry, for non-labour, I use the purchase prices of those clinical facilitator packs and the travel. For analysis, I descriptively analysed it at the residential aged care home level, and I mapped the strategies used to that list of 73, the ERIC terminology framework. So these are the results. And we found that on average, it cost about $9,500 per site for the implementation activities. We found that the majority of this was labour, which was not surprising, and that being made of the internal clinical facilitator. If I wanted to look at the costs by strategy and the activities under those strategies, I found that we had 2 strategies involved in this project, the facilitation and the context assessment, with the facilitation taking up most of those costs. And this figure here I find has the most interesting results, which I'll go through now. So this figure is the average weekly implementation costs per site across the study phases. So we had pre-intervention, intervention introduction, which was a short 4-week. This is what the intervention is going to do, introduction to each site, and then the intervention exposure. So first of all, we can see in the pre-intervention, there's kind of this general reduction across the sites, which likely reflects the learning curve of the study team and the increased efficiencies establishing in necessary processes over time. In the intervention introduction, there was relatively wide range in implementation costs, from $87 to $643, which was kind of surprising to see over a short 4-week period. But we'll come back to that on the next slide. And in the intervention exposure, just at this point, we want to note that the implementation costs continue to accrue at all sites throughout the intervention exposure, although there was some variation in costs. So why are those findings so interesting to me, particularly the last two? So the second one about the variation, particularly in that 4-week intervention induction period, was interesting because it actually really closely reflected the differing levels of engagement between each site and the engagement it had with the program as a whole. And these differences reflected that of what we found with fidelity. So the sites that had low fidelity also had low costs, and high fidelity had high costs. So it shows that costing the implementation can also support other findings of your implementation outcomes. The other point where we saw the implementation costs accruing during that intervention period is interesting because it highlights the tendencies for so the highlighting of the tendencies of implementation costs to extend well beyond the initial establishment phase. And this finding challenges the common assumption adopted in economic evaluations that suggest implementation costs are only upfront expenses that can be ignored when considering ongoing cost implications. And rather, these findings highlight the need to understand and account for implementation costs as they relate to ensuring the longer term sustainability of the new intervention in practice. I'll follow up now with some limitations and challenges during this process. It was hard to separate implementation and intervention costs from research-related costs. For example, when investigative meetings were had, we did exclude these as research-related costs, but implementation decisions could have been made at this time. I had a dependence on existing documentation because I approached this retrospectively after the study was done, which meant some key inputs were unavailable and there was aggregate documentation of some resources. So what I hope are the implications of costing implementation is that we have increased reporting in the literature, so that we have appropriate resourcing of implementation strategies that could lead to increased success of implementation, and that I hope economic evaluations include implementation costs to account for the full extent of costs, making sure that we have reliable information for decision makers. And once also we have a bit of data out there, we can cost effectiveness analysis of implementation strategies could be more common practice to help us choose the best strategies for our program. And I think I'll leave it there. Thank you.
Thanks so much, Tommy. That was fantastic. And Lane, thank you very much. Okay, so we've got a little bit of time for panel discussion now. And please, if anybody in the audience has any questions, feel free to post them in the chat. But I might kick it off a little bit just by asking, I mean, obviously, from what you've said, it's really important to think about embedding the costs of this up front. So for starters, for people who don't work, I mean, we're very lucky. We have a great team of health economists who work with our group. But how do you contact a health economist if you don't work with one? Tommy or Lane, either of you?
Yeah, that is a challenging question that I'm not sure I'll be the best at answering, because we do have health economists in our team as well. Up here at OSHI, we have implementation scientists, health economists, and statisticians, kind of all in the same group. But I think if I was going to, I've seen that ACTA has a list of like find a health economist. So that's probably where I would start. But I do acknowledge that I think Leigh mentioned in her presentation as well that sometimes there is a bit of a language use difference, and it is hard to explain what you want in a way that they would understand. So yeah, that could still be a challenge.
Yeah, thanks, Tommy. And Lane's just put a great link in the chat for Find a Health Economist. So that's incredibly helpful. And that's from the ACTA organization. So that's fantastic. I think it's important for people to have a think about not just being able to contact a health economist, but doing that early. So, Lane, how do you ask people to think about grant applications and stuff so that, they're able to embed the costs of this work at the start where it really sort of needs to be factored in?
Yeah, I think that can be really tricky because sometimes, well, I know for implementation costs, it's so context specific, and there's challenges around generalizability of the data that you collect. And so even pulling from the literature on available cost estimates can be really challenging. So you don't know what you don't know before you go into it. But I think there's even in the last couple of years, I've seen an enormous amount of resources and training out there and mostly free, that talks about these sorts of costs and these resource use implications. And so I would suggest, yeah, attending webinars like this, getting in touch with the different groups. I think Thomasina referred to, is it Eric, or for costing. I've found that people are really helpful. So if you find the senior author or contact details of someone on those publications there, they can always direct you and to where you might find additional information.
Thanks. Great. Okay. I don't see any questions in the chat, so I'm just going to keep on going. And guys, do please feel free to post if you've got questions. What you've spoken about is measuring direct costs, and as Tommy showed, the largest cost is really usually the staff or the labor cost. But that misses some of the information that people might want if you want to talk about research impact, or even for policymakers when you're talking about sort of translating this work. And that is the opportunity costs or the system level impact that you might be having. And I just wondered if either of you had a comment about, is there any way of capturing that, or is there a way that you describe that once you've got the direct costs? Is there a way that you can talk about system level impacts?
I don't really have an answer, so Lane can definitely jump in as well. But opportunity cost was something that I didn't get time, I think, to address in my PhD. But from my understanding, opportunity cost is the cost of that, using that resource for this instead of being able to use it elsewhere. And perhaps it's running those economic evaluations of the comparative between this intervention first that. But that, takes a lot of resource on its own, running that whole study. Be interested to see, if Lane has further insights on that.
Yeah, I guess when I think about opportunity cost of the intervention, I would say yes, it's the what you could have used the money for otherwise. Whereas with implementation, I often look at it from a time perspective. So if you spend all this time in developing an electronic medical record prompt, or if you spend all this time educating staff, that staff then aren't on the floor actually providing care to patients. And so I would collect, whether it's a sheet of paper, seeing who attended the education sessions. And as Tommy mentioned in her project, where she mapped people's time to their EBA, which is usually publicly available, and you can actually capture the amount of time that people spend participating in the implementation activities, so that you could compare those costs across the different strategies to work out what's going to be most cost effective.
Yeah, fantastic. That's great. So I guess one of the questions that people might have is that, like, there's obviously quite a bit of time and effort into collecting this data on top of everything else that you're doing within sort of, the implementation work or testing the feasibility or of an intervention. How do you balance methodological rigor with feasibility when you're collecting this detailed cost data? Like, is it okay in a complex health system to make some assumptions about costs and time and staff levels and things like that? Like how much detail? So, can you make an assumption about, an average level of staff or an average amount of time or an average cost of a piece of equipment that might differ between different places?
Yeah, I think I'll talk to this first, and then you can chat, Blaine. But yeah, we found in the interviews when we interview people, they were saying exactly that, how the burdensome of data collection itself, could not may not, but could outweigh the impact or insights that you get from it anyways. And if people don't want to do it, they won't do it and they won't do it correctly. So then is there even any point in trying to get that detail? So it really depends on your project and what you need. How much detail do you need? But I think what was nice from the case studies that I ended up doing was that all that data was already routinely collected. So the meeting minutes, the logs was done by just good project managers. So I was able to use already collected data to get the implementation costing out of that. So that could be one way of reducing data collection burden by reusing what's already available for different purposes. Yeah.
And Tommy, if the implementation costing changes over time or across settings, do you account for that? Like, do you look at a year by year increase? Like, do you look at annual increases in the implementation costs? And I guess this is just really important when people are sort of planning for scale up of something
Mm.
that they want to implement, right? So I guess my question is, how much variation do you factor into it?
Yeah, I don't think I looked specifically at year on year, but that would be interesting. I definitely was able to look at site first site, but as I said, that kind of only gave us insights into the fidelity or how closely people were relating. We didn't look at how the implementation was changing over time, but that would be very interesting. And I think you could look at that because, as you say, for scale up, you might have quite intense implementation and then kind of go to a maintenance to ensure sustainability, which I think you could measure along the way. But yeah, and I think it is fine to make some assumptions along the way. I think when I was measuring things like phone calls or emails, I think I ended up doing, I'd say 10 minutes an email or 30 minutes a phone call and just making all those assumptions really clear in the manuscript or however you're publishing the results.
Yeah, fantastic. And I really liked your 4 points, understand the project, identify the implementation strategies or activities, document them, and then value them.
Mm.
Lane, do you have another, like what would be your top tip for people who are sort of planning to do this sort of work around looking at the cost of implementation strategies? Do you have any tips for how people should go about it?
Yeah, I think my main tip would be to make the distinction between the intervention and the implementation strategy. And so, even if you aren't comparing implementation strategies, even if you aren't necessarily looking at fidelity or acceptability, maybe that's outside of the scope of your trial design or your study design. Even in your trial or your study, I think you can still report implementation components. So you might describe, this is how we implemented it. You might have some discussion around, why you think that was important and how that might have been involved in the effectiveness of the intervention and as a sort of exploratory secondary and analysis. I still think it's powerful to report implementation strategies alongside any of your studies. And I think it starts by making that distinction between the intervention and the implementation strategy.
Oh, I 100% agree. And I think when you think about any intervention, if it's found to be effective and people want to use it, they're going to want to know how to implement it and what's the most effective way to implement it. So with that in mind, from a funder or a policymaker perspective, what level of cost detail do you think is the most useful to support decisions about sort of sustaining or scaling up an intervention?
Going back to the assumptions question, I think in health economics, sometimes the costing data is actually really hard to collect. And that's for trials as well as for implementation strategies. And we often have to rely on assumptions around costs and resource use. And we can't capture every cost. And so we have to sort of create a parameter around what's feasible within the study. And so I think as long as you're clear and transparent about what's included and what is potentially excluded but important, I think that that's a good, starting point. I think for funders or for advocating for the type of research that you want to do, the tool that I created really focuses on the benefit to the patient population. So if you're able to quantify that there's a reduction in the length of stay at a hospital, or there's a reduction in outcomes that might impact resource use, collecting information about, those sort of long-term, really costly mechanisms is probably a good place to sort of focus on. So, and I specifically know, intensive care, and that is usually the length of stay is the biggest resource use for most patients, or for rehab or something like that. And so I would probably focus on those really high cost outcomes first.
Thanks, Layne. Tommy, do you have anything you'd like to add?
Not too much more. I agree with Layne, and I'd probably be aligning maybe my outcomes or effects to like the quintuple aim. So something about patients, something about provider satisfaction and costs, and see if I can get into equity and parts of that as well. So yeah.
Excellent. Yeah. So we're just about at time. I wondered if you had anything else that you wanted to add, Tommy or Layne, before we conclude the session. I think it's been a really fabulous conversation. I think people have a lot to think about in terms of looking at the costs of implementation activities within research. And I think that you've covered some really practical tips for people to take home. So thank you so much. I love that we'll be able to use the CostIS or Layne's tool. And I don't know, Layne, if you want to pop the website into the chat so that people can access it, and the CostIS one as well, Tommy, if it's available online, it would be worth maybe just adding that into the chat if you've got it. But if not, we'll make sure that we can email it to people if they're interested. Oh, there we go. There's the CostIS. Thank you. Great. Okay. Any last comments from either of you?
Just a few things that came up in our discussion. One around data capture, and one challenge I did have, which I'm sure other people will as well, is when you have healthcare workers who are participating in implementation as well as their clinical time, that distinction between clinical time and implementation time was very difficult for them to even conceptualize, because it's all part of their job. So that could be one area that is difficult, and assumptions do need to come in, saying, 10% of their role was towards this. And then something else to note that Carol, you did bring up, that my tool looks at direct costs and also tangible costs. There are a lot of intangible aspects of resources that make implementation successful. So example, if you had a champion or an on-site facilitator who had worked in an organization for a decade compared to someone who was just there a year, they probably have a lot more knowledge of the organization, which will really be an enabler to implementation. But things like my tool can't capture that at this point. But there are other things to consider for implementation success.
Thanks. And just two quick questions in the chat. Rory looks like a really great model. Have you linked specific literature resources to the factors assumptions that underlie the model?
Yes, there are in each of the sort of tabs, which I will share the link as a follow-up email. There's just I've got to tinker with a few things on my list before I'm ready to sort of share it out there. But I'm also happy to take feedback. So by email, if anyone uses the tool, and they can provide their comments to me. Yeah, so there are literature sources throughout the tool that link to, you know, the underlying model, as well as the ways that you can improve the inputs that you provide, because the output is directly related to what you put in. So it's really important to get the inputs right. And so there's some guidance throughout the tool to say, you know, where to get your inputs, where best to find the appropriate literature to support your return on investment calculation.
Thanks, Lane. And there's a question from Jacqueline Bishop, which I think I can answer. Do these models support small-scale work in a small health service, e.g. single-site implementation? And the answer to that is yes. Everything that we've shown today is applicable for small and larger scale work, which is fantastic. So on that note, I'm going to say a huge thank you to Lane and Tommy for your time and expertise today. And we will make sure that this webinar is available online on the Monash Partners website. So thank you both so much.
Thank you.
Thanks, everybody.
Thank you.
Bye.